Hello and welcome back. Today we are going to do something different. So this lecture is not specifically designed for patients or family. This is a lecture specifically designed for a primary care provider and especially physical therapist and also occupational therapist and speech therapist. So this is a very, very important topic because we see a lot of these type of patients in the clinic. I'm talking about functional neurological disorder, but we are going to talk first about pattern recognition, and I will explain you what I mean with that. So let me start saying that in movement disorder, the approach is different from general neurology. What do I mean with that? So in general neurology, you start asking yourself the following question. Number one, if this is a neurological problem, which usually the answer is pretty easy, usually, but not always. Then, if you say yes, okay, the next question is, where is the problem? Location. Is the problem in the cortex? Is the problem in the brain stem, which is the back of the head? Is the problem in the spinal cord? Is the problem in the nerves, peripheral nerves, or in the neuromuscular junction, or the muscle? But in movement disorder, that doesn't help you. Location is not too important. The most important in movement disorder is you to be able to tell me what do you see. We call that in medical terms phenomenology. So, and this is what we call pattern recognition. And that's why this is so important. Because if you cannot tell me what do you see, what you see, this is a tremor, if this is a dystonia, or this is Parkinsonism, then you cannot have the correct diagnosis and the patient will receive the incorrect treatment. So that's why this is so important. Let me give you an example. Last Saturday, I got a consult for in the hospital for tremors. And when I saw the patient, there's no tremors at all. The patient was having myoclonus, multifocal myoclonus. So, and the management and the cause is totally different, but you need to know the phenomenology. Otherwise, you are going to give the patient the incorrect treatment. That's why it is so important. Now that we talk about that, let's dive in. Non-disclosures, objectives. So basically, we are going to talk about the basic terminology, clinical approach, phenomenology, differential diagnosis, including functional movement disorder, which is approximately 10 to 20% of the patient that I see in the clinic, in the movement disorder clinic. And at the end, we will talk about the role of rehab, specifically PT and OT, in the management of those patients with functional neurological disorder. What is the approach? Let's talk about phenomenology. Remember what I say about phenomenology, which is the most important part, pattern recognition. So many people use a different type of animal to explain this concept. So there are people who can identify what type of big cat is here on the left and what type of cat is here on the right. So, and you need to know that only one detail is not enough. You need to have a cluster. So you need to see the whole picture, the whole thing, not just one thing only. So not just the color, not just the rosette. You need to see the size, the background. The background help you. What is around everything? It's not just one thing. So if you see, there are differences. One of them is the head is larger, and the rosette they have dots. So if you know a little bit more about big cats, you will know that this is the jaguar and this is the leopard. You can get better identifying this, but you need to practice. And this is the best way to explain how important is pattern recognition, especially in movement disorder. And if you want to get better, you need to watch videos, a lot of videos, see a lot of patients, film the patient, videotape the patient, obviously with consent, right? And watch those videos in slow motion. And this is the only way to learn about pattern recognition. Now, movement disorder is a subspecialty in neurology. In neurology, is very, very specialized field. In the same way that internal medicine. After you do residency in internal medicine, you do cardiology, GI, rheumatology. In neurology, you do critical care, you do vascular neurology, you do neuroimmunology, which is MS, you do movement disorder. So you see, it's a very specialized field. So movement disorder take care of everything that move abnormal. You name it. There are many things that move abnormal. And the management/treatment. Okay? There are two options, two options in movement disorder. Or you move too much, right? That we call that hyperkinesia, or you don't move too much. The opposite, too little, which is hypokinesia, right? Let's start with, and before going there, these are not related with weakness or spasticity, okay? Now let's talk about hypokinesia. So hypokinesia is mostly divided in two main areas. The Parkinsonism and a non-Parkinsonism etiologies of the hypokinesia. Hypokinesia is the big term. Hypokinesia means decreased amplitude of the movement. It's just decreased amplitude of the movement. Now, Parkinsonism is the most common cause of hypokinesia, more than 50% of the time. The rest is all these things that you see here, which I don't have the time to talk about them, but Parkinsonism is by far the most common one. And if you ask me what is the most common cause of Parkinsonism, and you just want to guess, you can say Parkinson's disease, and you will be right in approximately 70% of the time. The rest will be something else. Now, let's talk about what is Parkinsonism in the setting of Parkinson's disease. In the setting of Parkinson's disease. So you need to have bradykinesia. Brady means slow, kinesia means movement. So slow movement, but not only that, you need to have either or a resting tremor. Remember, tremors are divided in resting and action, and stiffness or rigidity. Bradykinesia means slow movement and decrement in the amplitude or speed of the movement. Either or. Usually both, but you can have any of those characteristic. Or you have a decrease in the amplitude or decrease in the speed, the decrement. You have a decrement. Like a patient, sometimes you have, when you make the patient to do loops, you see that a cone form. So start big or normal and then go decrease. This is the decrement. Okay, you see that when you have significant Parkinsonism, significant bradykinesia, moderate or severe. Sometimes when it's mild, you cannot detect that. It's more difficult. Now, how do you evaluate bradykinesia? Well, very simple. 10 seconds with the fingers, finger tapping, or hand like this, okay? In each hand, 10 seconds. You are looking for decrement. I'm talking about in the setting of Parkinson's disease. Pronation and supination, okay? Like that. And foot tapping or heel tapping for 10 seconds looking for the decrement. Now, rigidity, the first thing that you have to do is you make sure the patient is relaxed. If the patient is not relaxed, that doesn't count. Why? Then the patient will have paratonia, which is a lack of relaxation. You need to make the patient feel relaxed, relax, relax, relax. Okay? Now, when you move, and you will see the video, I have a video, you move, I always usually start with the or proximally or distally, and then I go up by joint. So I go the shoulder, then the elbow, and then the wrist. Okay, not just the elbow. You have to have rigidity in all these joints in order to call it. And then this is not velocity dependent, different from spasticity. Spasticity is velocity dependent, depend on how fast you move the joint, right? Here it doesn't matter. It doesn't matter the direction. If it's up and down, you feel the stiffness, you feel the rigidity, which is different. Spasticity is velocity dependent, depend how fast, and the direction too is important in spasticity. So this is so important that you know how to differentiate between rigidity and spasticity, because the etiology is different. Now, remember that cogwheeling is the effect of the tremor. So, for example, in essential tremor, you can have cogwheeling phenomenon, but you cannot have cogwheeling rigidity in ET, essential tremor. Okay? So, let's watch this video. What I do, I will rest. Patient should be very relaxed. And I tell her to open and close the left hand, open and close the left hand, and I see more resistance. Okay, this is the Froment sign. So sometimes I go here too. That's the Froment sign. Work with circular motion, and you feel the resistance in every direction. It doesn't matter, every direction. In spasticity is velocity dependent, velocity dependent. So this is not spasticity, this is rigidity. And then in this side, so this is a patient with Parkinson's disease. Almost normal. I don't feel any rigidity. Open and close the right hand, open and close, and a little bit now. So it's a 1. The same thing here. So we can classify that from 0 to 4. Here. Okay? So this is how you check for stiffness, rigidity at the level of the arms, but you can do that in the legs as well and in the neck. What I do. Now, let's talk about what is normal aging and Parkinsonism. Let's see this guy here. So finger tapping. He looks slow. Kind of have a mask face, but nothing significant. But there is no decrement. There is no decrement. Okay, I'm not convinced about decrement. I need to see more. Okay, don't overcall. So full hand now. Okay. So remember what I say, you need to see clusters. It's when you are evaluating somebody for body language. It's not just one thing. You need to see cluster of things. Okay. So full tapping. This is pretty normal. Okay. And then, okay, so let's see him walking. How he walk. Normal gait. Look at the arm swings. Normal. No tremors during walking. Look at the pendular phase of the walking. So completely normal gait for age, right? No freezing, no hesitation, nothing. Now, let's watch this one. These 2 fingers. Look at that tremor. Whenever you see this type of tremor, resting tremor, this is a resting tremor. This is Parkinson's disease until proven otherwise, okay? This is Parkinson's disease. This type of tremor is Parkinson's disease on the
Okay, now show your hand.
This is also very common. The patient do. It's just like a cheating, trying to
The other hand.
going faster.
Okay, now like this. The other one.
You should wait 10 seconds to see the decrement. And you see the difference between the right and the left. There is asymmetric. So the left is faster than the right.
And I want you to do this. Huh?
Observe. Let's pay attention to the speed.
Okay, the other side.
It's faster on the left. And even the amplitude is higher on the left.
Okay.
And it's not due to weakness.
Put your hands.
She is not weak.
Stand up. Put your hands down.
Now let's see how she walk.
And then let's walk. Open the door.
Always let the patient open the door.
And make a left.
You don't open the door. Let the patient open the door. Look at the right hand tremor. Decrease arm swing.
Come back here.
And even the leg, the pendular phase of the right leg is decreased as well.
Up there.
Okay, that's classic. So this is normal aging, right? And a patient with Parkinson's disease. Very classic.
With 2 fingers.
Now, if you want to know more about early symptoms suggesting Parkinson's disease, watch this video. Okay, this video will tell you what to look for: motor and non-motor. Now, what about if it's not Parkinson's disease? Then what? What is it? Okay, remember what I told you. You have Parkinsonism, which is the big term. Parkinsonism just means that you move slow and you have decrement and you have resting tremor or rigidity. Okay? That's the only thing that you need to say that you have Parkinsonism. And if you want to guess, you can say Parkinson's disease and you will be right in 70% of the time. The rest will be something else. And then if you ask me, what is something else? Something else means that it's something atypical. Atypical. Typical means Parkinson's disease. But when it's atypical, you have a bunch of things. Many things that can cause Parkinsonism and looks like Parkinson's disease, but on steroids. Okay, so the symptoms are more severe and they are more, it's a fast progression, progress faster. So you see those patients having significant gait dysfunction during the first 3 years that you don't see that with Parkinson's disease. Or at least very unlikely to see that with Parkinson's disease. So if you ask me which one of these conditions that you see here are the most common neurodegenerative disease, one of the atypical Parkinsonism is PSP, okay? PSP. Dementia with Lewy body is part of the spectrum of Parkinson's disease. It's not the same. Even there is a controversial about if this is the same animal. I don't think so. I think that these are different diseases. The only thing is that we call all of them Parkinson's disease because we don't know how to call it. And I'm assuming that at some point in the future, many of the Parkinson disease subtype will have a different name. Because I think that there are more than just 3 types of Parkinson's disease. It's just a spectrum. It's like saying that autism is only one. There's a spectrum of autism. In the future, I believe this is going to change. The definition will change. Let's see what happens. So, another important cause of Parkinsonism that you see in the clinic is medication induced. If I give you a medication that blocks dopamine, you will look like a patient with Parkinson's disease, but you don't have Parkinson's disease. You have medication-induced Parkinsonism. That the treatment is stopping the medication, and sometimes even decreasing the medication would be enough. But typically you need to stop the medication and then you wait. You can wait 3 months, 6 months, and even some case report even 18 months. The question here is that we have is why some patients develop drug-induced Parkinsonism and another ones no. Maybe because those patients will develop primary Parkinsonism at some point in life. I don't know. But clinically, there's no way to differentiate these two entities. There's no way I can differentiate between drug-induced Parkinsonism and idiopathic Parkinson's disease. Okay? I say idiopathic like this because right now, I don't know if we should call it idiopathic. There is a lot of, this is another topic, but environmental factors is probably the main cause of Parkinson's disease. But again, this is a different topic. But let's call it idiopathic now. Again, we cannot differentiate between Reglan-induced Parkinsonism or anything that block dopamine, especially D2, and idiopathic Parkinsonism. You can differentiate doing a skin biopsy, which is a SIN1 test, or better, a DAS scan. A DAS scan would be even better in my opinion. Okay? Now, if you see, you have here psychogenic, and I don't want to call this psychogenic anymore. Okay, this is an old term. We should not call this psychogenic because this name doesn't help anybody. Okay, doesn't help anybody. Functional is the way to go, even though that some patients, I will talk about that later. Functional for patients is difficult to understand as well because many of them, these are smart people that will tell me, why you guys call this functional? There is nothing functional here. Everything is dysfunctional. And they are right. Okay? But my point here is that functional Parkinsonism is a very, very rare entity. Okay? And you can have patients with Alzheimer also with Parkinsonism. And we believe, we're not sure, that this is because this is mixed with a dementia with Lewy body. Okay? Let's talk about a few of them. Now, briefly, I'm showing this video for you. This is a patient with MSA.
Put your hands up.
A patient clinically established multiple system atrophy Parkinsonism. Listen to the noise, the breathing. This is classic for those patients. Okay? This is classic. This is the name, right? Okay, look at the mouth, open, Parkinsonism. And I want you to check the fingers. Check the fingers. This is what we call polymini myoclonus. Boom, polymini myoclonus here, okay? This is not specific for this condition. You can see polymini myoclonus in any type of dementia, but is highly supported, one of the supported criteria for MSA. So the key feature here, the core feature here is that you have severe autonomic dysfunction, which means that the patient blood pressures drop when they stand up significantly, okay, very pronounced from the beginning, or they have retention. Retention and Parkinson's disease doesn't fit. You need to explain why the patient have retention, because retention is a big red flag. Okay, that doesn't fit well. You can have urinary urgency, obviously, in Parkinson's disease and stress incontinence, but retention is not a feature seen in people with Parkinson's disease. Unless you need to explain that with something else. Okay. Now, another core feature of this problem is either they have cerebellar dysfunction or they have Parkinsonism that doesn't respond well to levodopa like in Parkinson's disease. And they have supported criteria like all these things that you see here, okay? It's like I tell patients and family, actually I tell family that MSA is like having Parkinson's disease but on steroids. Okay, on steroids, because rapid progression and you have this breathing, you have a lot of breathing issues, You have these noises. You're acting out during sleep. But you can see that with Lewy body and Parkinson's disease as well, because all of these conditions, MSA, Parkinson's disease, and dementia with Lewy body, they are synucleinopathies. And they share many of these features. Okay? Now, let's talk about PSP. And this time, I'm going to talk about the most common one, which is the RS. RS means Richardson syndrome. Okay, Richardson is the last name of the guy who talked about that many years ago. So the key feature is falls from the beginning. These patients are falling down from the beginning. Not in 5 years, not in 10 years. No. From the beginning. They have significant, prominent postural instability. So you pull them from behind and they fall like a tree. And many of them from the beginning, but not always. In Richardson syndrome, they need to have that, which is decreased mobility of the eyes downward. Okay? Downward, looking down. They cannot look down. Initially, just slow. They can move initially, but very slow. But then with years, you see that they cannot look down. And then when they walk, and you will see a video that I have, they walk and the eyes, the head is like going backward. Okay, and this is a technique that they use, I guess, because they cannot look down. So they need to hyperextend the neck so they can see something. And they have this particular type of face, like excessive contraction of this muscle here, that we call that the procerus. We call that the procerus sign. Or they have a like surprise face, like excessive contraction of this muscle here that we call the frontalis. Okay, so this is characteristic features, and also they have increase of the nasolabial folds. Okay, you see this here? This is also very characteristic, but not every patient is the same. You see, this patient had the procedural sign. This patient has activation of the frontalis muscle with eyebrow are elevated. Many of them, they look like this, a surprised face. And they have significant stiffness in the neck, in the trunk. Not too much here, okay? At least in the beginning, not too much in the arms. It's the trunk. So let's see a video, real patient. Watch this.
So he came with sunglasses.
Sunglasses.
And just to summarize, he started.
Let me stop here. When you see a patient in the clinic with sunglasses at this age and looks Parkinsonian, this is most likely PSP. Most likely PSP. Younger patient with photophobia, migraine. You see, things come to your mind quickly. But not always, right? Remember what I say, clusters. It's not just one thing.
So he came with sunglasses. And just to summarize, he started having walking issues, balance issues, approximately 2 or 3 years ago, right? Yeah, more or less. Okay.
Yes, significant expressive aphasia.
Look the camera, okay? Look the camera.
Look at
and follow my finger with your eyes.
Muscle, the eyes.
Look up.
Eyebrow
Look
elevated.
down.
You cannot look down.
Your head, your eyes only. Look up. Look down. Oh, okay.
You see that? Let's see this one.
Can you stand up?
Look at the gait of this patient. Standing. Typical walking of patient with PSP, Richardson syndrome.
Okay. And walk a little bit here. Walk a little bit. Okay. Turn around.
Look at the arm. Some of them,
okay. Perfect. Pivot, go back to your chair.
But not always. So when I pull this patient, testing posture instability, they will fall like a tree. So they fall a lot, and that's one of the core criteria for PSP.
Can you stand up?
Now, cortical basal degeneration. I have not seen any patient with cortical basal degeneration in my clinic. During fellowship, yes, I have one or two. I see patients with cortical basal syndrome, which is not the disease, is a syndrome. So there are other conditions that they have this pattern. For example, there are PSP, cortical basal syndrome. Okay, so when the patients they get autopsy, you see PSP, but the patient, the phenotype is like cortical basal. It's a mix. It's a mix. So yeah, and you see the asymmetric of the MRI, and those patients are very, very, very asymmetric. So very Parkinsonian on the opposite side of the atrophy. Okay, and they have apraxia, they have myoclonus, they have dystonia, and they can tell you that, oh, my hand move by itself, I cannot control my hand, that kind of things. And they have cortical sensory disturbances. Now, remember, if you want to know more about PSP, just watch this video, okay? This is in my just look for this video in the search icon, and actually it will be in the description of the video. The link will be in the description of the video, this video below. So remember what I say. Parkinsonism is the big term. It's a big term, and then you have many causes of Parkinsonism. The most common one is Parkinson's disease, but then you have the atypical Parkinsonism here on your left. You have the functional Parkinsonism, which is very rare. You have to be careful because this is very rare. And you have the secondary causes, which means that medication-induced, vascular, and toxins might cause that. Even NPH. So, and the diagnosis of NPH is very difficult because pure NPH is very, very rare, but exists. Now, let's talk about we talk about hypokinesia. Let's talk about hyperkinesia. So, too much movement. The patient is moving too much. So, we talk about myoclonus already, right? Myoclonus, I show you a video. I don't have the time to talk more about that. Myoclonus is the fastest movement that you have. Very fast. You cannot control that. Okay? It's just boom, come. So let's talk about ataxia, chorea, and dystonia. Ataxia is the decomposition of the movement. So instead of having a smooth, continuous, coordinated movement, you have this movement that wander trying to reach the target, okay, in different axes. So you have different axes, not just one axis. You go like this, trying to get the target. We call that missing the target. In medical terms, we call that dysmetria. That's dysmetria. And you have intentional tremors. Intentional tremor. Intentional tremor means the terminal tremor. In movement disorder, the tremors are divided in resting and action. Resting is the easy one, okay? Action is divided in postural and kinetic. And the kinetic is divided in the kinetic also you can have the terminal tremor, which is the intentional tremor, which is the tremor that I'm talking about here, which is when you are reaching the target. When you are reaching the target. And this is what you see in cerebellar problems. And patients with essential tremor also, they have intentional tremors because we believe that the pathology in essential tremor is coming from the cerebellum. Okay, so you test ataxia during action, during voluntary movement. You don't check for ataxia during resting because this is a problem that you see during action.
Okay.
Let's watch this video.
Both hands up.
So action tremor should not be during resting, only during action.
Touch your nose with the
Look at this tremor, which is very proximal. Look at this symmetry.
Okay.
Very bad.
Nose again. And your nose.
Overshooting.
And my finger.
Slow frequency, high amplitude tremor.
Okay.
And the tremor is in several planes.
Both hands up.
X, Y, Z. Okay. So just to get an idea, this is a patient who has a lesion in the lower midbrain. Okay.
With the
He had a lesion there. And that's why she is having this problem due to a lesion in the lower midbrain.
And my finger.
At the level of the inferior colliculus.
Now, both hands.
Now, Korea, think about dancing. Dancing, Korea. Okay? You cannot predict where the movement is going. Okay? You cannot predict, you cannot tell. Different from dystonia. And dystonia you can predict because the movement are pattern. It's the same group of muscle always in dystonia. In Korea, no. Korea move randomly to one side to another one direction to another one. You cannot predict. When the patient is telling you, doctor, I'm dropping things, you always think in two things. Or is myoclonus, which is most commonly, or chorea. Okay, very severe chorea, patient can actually drop things. In Korea, many times, but not always, they have what we call motor impersistence, which is it's what we call negative chorea. The patient cannot sustain a contraction. You ask the patient, squeeze my finger, and it's like they are doing this milkmaid grip. Okay, you tell the patient to stick out the tongue, and they cannot sustain the contraction. They stick out the tongue and they put it in and out, when they have moderate to severe chorea. When it's mild, this doesn't apply, okay? And this is the spectrum. You have atetosis, which means a slow chorea, the chorea, and the balism. Balism is a proximal movements, and this high amplitude, fast, this type of movement, balism. Now, let's see this video on this. Let me give you the story, and you think about this. So this is a 19 years old with frequent strep throat infection since childhood, who started having this abnormal movement, involuntary movement, at age 16. The MRI of the brain, it showed a mild hyperintensity in the right putamen region on T2 flare. So you see it's only one side, hemichorea. So obviously this is a very, very, very asymmetric, right? Well, actually, it's hemi, it's on one side. So this should be a structural issue. Something is going on the opposite side, on the right side.
Open your eyes. Put your hands up, both of them.
Where? I don't know. That's why location doesn't help. So it could be in the basal ganglion, but well, in this case was the putamen. Okay, you repeat the MRI later, and the MRI looks better, significantly better. And at some point, I think the last few MRIs did not show anything. But this is a rare case of persistent Sydenham chorea. Okay. Dystonia. So dystonia, remember, dystonia is excessive contraction, abnormal posturing. You have typically the brain sends signal to the agonist and antagonist. So activate the agonist and inhibit the antagonist. In dystonia, send signals activating the agonist, antagonist, and coagonist. So it's just sending signals in the incorrect way, and this is why you have this distortion of the muscles, okay, and this abnormal posturing. But the key here is that is stereotype. pattern, stereotype, the same type of movement. Always. And it gets worse with action, no matter the stage, usually. There are very rare cases documented, I guess case report, because I haven't seen that dystonia during rest. I haven't seen that, but it's documented in books, but I haven't seen that. I don't know. Always they have overflow activation. So you activate other areas of the body. For example, you tell the patient to walk on tiptoes and you see the arm posturing like this, okay? You ask the patient to write with the right hand and you see that the dystonic arm start crawling like this, okay? So this is overflow activation. And they have sensory trick. They have and you see the video of the next patient, they touch the chin and the tremors improve and the posture actually improve just touching only, just with touching, okay? Many patients, they have dystonic tremors, which is actually no tremors because they are not oscillatory movements, but I call it tremulous movement. They are kind of jerky and they have directionality, which means that the tremor get worse during a specific position. Okay? When the tremor get worse, it's like you are moving your neck or your arm against of whatever the brain is telling you to do. And the brain is telling you, hey, where are you going? Come back. And that's why you have the tremors. Then if you allow the posture, the neck, the hand to go to whatever the brain wants to do, then the tremors goes away or decrease significantly. And we call that the null point. And this is a very characteristic for cervical dystonia and dystonia in other areas like the hand too. Okay? Look for this type of features because they are very characteristic. And you don't see that in functional dystonia. We'll talk about functional dystonia soon. See this guy.
Okay, let the neck do what the neck want to do.
So you see, and you see the sensory trick right there. Sensory trick, which is not working well.
Turn the neck to the left.
So he's going against
right.
whatever the brain is telling him. So it's easier for him to turn the head to the right because this is the position that the brain wants him to place the head. Okay? So that's cervical dystonia. The main treatment here is no pills. Pills are not going to touch that. Is botulinum toxin injections. Okay? And the key here is muscle selection, doses, but 20% of the patients don't respond. And for whatever reason, don't respond. And then many of those patients require surgery. And when I say surgery, deep brain stimulation, okay? Deep brain stimulation is the way to go when we cannot help patients to be functional with Xeomin, Botox, Dysport, all this medication, okay? Now, this is a very interesting case. Watch this video.
So tell me, when did you start having abnormal movements? At what age, more or less?
In my arm, it was 12, and then my neck was when I was.
Pay attention about the pattern. Abnormal muscle contractions, the same group of muscle, and get worse with inaction. Look,
And do this.
you see how get worse with action?
Okay. With the right hand, do this. He can pass.
So antagonists, coagonists contracting at the same time, and you have this torsional movement.
Let's do this. The other one. Okay. Now turn the head to the right.
So this is what we call
The left.
primary dystonia, Oppenheimer dystonia, okay?
Then forward. Backward.
So those patients do very, very, very well with deep brain stimulation. You always try botulinum toxin injection. You always try, even though that you know that is not going to work well because it's so severe. But you always try just in case. I tried probably in this lady 4 or 5 times, and I reached I think 500 or 600 units. Didn't touch her. Did not touch her. No side effect, but didn't touch her. It's like injecting water. So we decided to do deep brain stimulation, and look how this is magic. Look at this.
Turn the head to the right.
So this is the target that we use, GCI.
To the left. Okay.
Look at how happy she is. This is amazing. This is 3 months. I don't have a video of her 6 months, but at 6 months she was even better.
Good work.
Look at this. She's obviously she still have dystonia.
You're working now.
She still have dystonia in the left leg,
You're working.
but the neck improved significantly.
Perfect. Come back here.
This is amazing. Okay. Now tremors are the typically easy one. So remember, tremors is a rhythmic, have to be rhythmic, even though that the essential tremor could be a rhythmic too. So you have a tremor, and it's kind of a rhythmic type of tremor. Still could be essential tremor. Okay, don't rule out because the tremor doesn't look rhythmic, because sometimes it could be also a rhythmic. But technically, tremors have to be a rhythmic oscillatory movement. Okay. Now, I want you to see this video just to show you the technology that we have. Okay? This
Okay, put your hands up.
very bad essential tremor. Very bad essential
Touch
tremor.
your chin with the right.
This is
Back
very
and
bad.
forth. Keep doing it like this.
So let me tell you something about this patient. Obviously, this patient tried all the medication that you can imagine. Primidone, propranolol, Topamax, gabapentin. That doesn't, none of those medications touch him, because those medications decrease the amplitude of the tremor maybe 50-60%. So from here, you decrease here, you still have dysfunction. So those patients require deep brain stimulation or MRI guided ultrasound, which is another topic. But I personally prefer deep brain stimulation, and this is what this patient got. And look the magic. Oh no.
Okay, put your hands up.
So it's off.
Touch your chin with the right.
I turn off
Back
the
and forth.
EBS.
Keep doing it like this.
It's off.
The other one. Oh, be careful.
Very
Okay.
bad.
Now,
Very
put it
bad.
on. Put it down.
So let's turn this on. 3 seconds.
Better? Yeah.
3 seconds. Very happy.
Okay, put your hands up. Look at that. And then the other one.
Look at that.
Wow, that's great.
Okay. So that's essential tremor post BIM, deep brain stimulation. Okay. Let's check your understanding. See this patient and you tell me
Just
if
keep your
this
eyes
is
closed for a few
matter,
seconds.
if this is stereotype movements or
Just
not.
take a deep breath. Let the neck do whatever the neck wants to do.
Are the same muscle contracting?
Open your eyes now. Close your eyes very tight.
Are the same muscle involved?
Okay.
And believe me, that the face, the jaw was moving to each side.
I want
Okay.
you to look to your right. Red 97. Keep going.
To the boys. Look at the head to the other side. So these are not stereotypes. This is not organic dystonia. Dystonia is not like that.
No, I want you,
Look the other side.
Just
You see the other side.
Don't tell me the number. Just start from 100.
So the movements are not pattern here, okay? So she looks like a dystonia, but it's not the organic dystonia because the movements are not stereotyped, okay? And it doesn't get worse with action. Actually, during resting, it gets worse. So that doesn't make sense from the organic dystonia standpoint, okay?
Just keep your eyes closed for a few seconds.
It's functional dystonia. Let's talk about the tremor here. Look at this tremor. This is automatically.
You just let your tremor go, do whatever it wants.
Look at the doctor, what the doctor is telling her. You see, changing frequency, amplitude, and even location, and even direction.
Okay, I want you to say for me, today is a sunny day in Omaha, Nebraska. Today is a sunny day in Omaha, Nebraska. Very, very good. I want you to count backwards by fives from 100. 100, 95, 90, 85, 80, 75, 70. Good. Now I want you to count backwards from 100 by, let's count backwards by 7.
Now look at this one.
Relax, take a deep breath. Okay, now put your hands up, both of them. Okay.
Observe the changes in the frequency and amplitude.
Now, with the right, touch your nose, back and forth.
You see, stop the
back
tremor when she starts
left.
moving the right hand.
Back and forth. Keep doing it. Keep doing it. Keep doing it. Keep doing it. Okay. Good. Keep it like that. Now this one down. And don't follow me here.
Tell the patient to concentrate on the right.
Okay.
You see, both way.
Okay, stop. Okay, let's do it again. Concentrate in my hand. Don't worry about your hand.
Very important that you involve the patient. Tell the patient what are you doing. Because when the patient understands what's going on, then it will be easier, the treatment, believe me. So involve the patient in the evaluation.
Got it.
Okay, and this is what happened 2 months after FND, Functional Neurological Disorder, Focus PT.
Okay, now put your hands up. Take a deep breath. Okay, good.
Look at the face.
Arm like this, both of them.
She's very happy.
Perfect.
Now,
Like this again. And then touch your nose, back and forth, back and forth, back and
away.
forth. The other one. Back and forth, back and forth. Perfect. And you tell me, so are you doing well now?
It's like it's almost gone.
Almost
It's,
gone.
I mean,
so you
can see it's gone. Sometimes I can still feel it.
Yes. Yes.
But it doesn't impact
Perfect.
anything I do anymore.
And you were getting physical therapy.
I got physical therapy for a couple of months.
Couple of months with
and
Gina.
Just finished with Jenna, yeah.
Gina.
She's doing finished in the end of May.
She's doing a great job.
She's fantastic.
Good. Perfect. Good. Thank you.
Now let's talk about functional neurological disorder, or actually functional movement disorder. I should put here movement disorder. Now, I don't want to call this psychogenic anymore. Why is that? Because that doesn't help. Doesn't help me, doesn't help the patient at all. So this is the old term, okay? I want to call that functional, even though that functional still is not a good name, because patients still don't understand well when you just say you have functional neurological disorder. They don't get that. You need to go explain more than just saying functional. because for them, there is nothing functional here. It's dysfunctional. So when we talk about gait, walking disorder, this is the typical type of gait that you see, okay? First of all, you need to know what is normal. And there's no better professional than a physical therapist to know what a normal gait is, right? Why? Because they are the only professionals that I know that they spend months just studying gait. So the book that they have, gait analysis, I remember it's a green book. It was like this, okay? So they know very well gait analysis, believe me, okay? Way better than the physician. So they know how to identify these abnormalities. So unilateral or bilateral, sometimes alternate dragging of the leg, that's characteristic. There's some type of gait that we call robotic type of gait. That's characteristic. This type of gait is very common, actually, walking on ice. And you will see this in the next video, walking on ice. This one is very, very, very common. So when you see a patient having sudden buckling of the knee, okay, this is usually two things. Or the patient has a negative myoclonus, or this is a functional gait. Okay, we call that bouncing of the gait, bouncing of the gait. Also, when the patient, even without asking, the patient start doing this type of walking, acrobatic type of walking. And the facial expression looks, remember, you have to see the whole picture. It's not just one thing. See the whole picture. The facial expression, suffering type of gait. And there is a lot of variables. So it's just change, inconsistent, lunge, near fall, but rarely have a actual fall. So let me show you a video of a patient, because the best thing is
The biggest one
watch
for me,
videos.
is that
Let me
they
stop here.
can cause
So when you are seeing patients, I will recommend you to stop talking. I see, you know, I have been in many programs, and I have been in many residency, fellowship training, and I had very bad attendings and very good attendings. And you always remember the bad ones and the good ones. The good ones are the ones that allow the patient to talk. Let the patient spread themselves. It take you 3 minutes, maybe 5 minutes, as much, but let the patient talk. You will get a lot of information. Let the patient talk and stop talking. Observe.
anger or unusual outbursts. And I've been doing that a lot.
Check the voice.
lately.
The voice change.
Just, I guess, the speech and like it just comes and goes.
Good days and bad days.
I might wake up 1 minute and feel fine, and then maybe, I don't know, 5 minutes later, an hour later, I'll just.
So you say that sometimes you might be one day completely fine without any symptoms.
But let me stop here. Remember, fluctuation is not enough. You can have fluctuation in many organic diseases. Remember what I say, clusters of things. You have to put everything together. This is the beauty of neurology. You have to put things together.
Some days very bad, like today, like walking like that.
Yesterday was a good.
Yesterday was a good day. Okay.
Okay. So what you say yesterday was medium?
Look here.
Behind you.
I just told her just walk. That's it. That's the only instructions. Just walk and observe how she walk.
Don't fall.
This is a type of gait. What type of gait is that? The bizarre
Okay, come
gait.
back here. And can you walk like this?
And there is no weakness, by the way. Look at this. In one leg,
Good. Good, good.
and she doesn't fall.
Good. Okay. Good.
Okay? Look at this.
Good. And stay there. Stay there like this.
Classic, classic, classic.
Keep walking. Uh-huh. And you run.
Look at this.
Let's try.
Like,
If you can. Oh, wrong here. Come.
run.
Perfect. Perfect.
Able to run.
Good, good, good. Okay.
Okay? He run better. Look at this.
Just walk.
2 months with therapy. Look at this. Boom, boom, boom. That's abnormal. Completely normal.
Come back here.
That's the baseline. You might say, but she's not normal.
Faster. Faster.
Well, normal for her. Okay? So let's talk about other features that you see in functional gait, okay? This is a type of gait that you see in patients with what we call monoplegic, which is one leg, or hemiplegic. Hemiplegic means that involve the leg and the arm, okay? So you see that many patients rotate, sometimes in externally rotated the hip or internally rotated, okay? So it's not consistent. And when you are talking about spasticity, so spastic hemiparesis from a stroke or a lesion, corticospinal tract, this is the typical gait. It's a circumduction gait. Okay, this is the typical gait, not this one like this. No, this is like a sack of potato. This is a classic for functional gait. You need to pay attention for these things. Now, this test is pretty good because the specificity is very high. Some even in this paper, 100%. So when the patient, if you know what you're doing, and you find this, it's pretty good. The sensitivity not too good, 63%. Okay, so how do you do that? And actually, there another one is some people think that the abductor sign is better, and it's the same principle. It's the same principle. Okay. But let's talk about the hover sign, which is the one that most commonly is used. Okay, and it's easy, but also the abductor too. So this is the patient is complaining of, doctor, I cannot move my right leg. Okay, so patient is on the bed, right? You tell the patient, okay, push my hand down, and the patient cannot move. The patient cannot move. Okay, no move. And then okay, then lift the left leg, this one. Okay, patient is able because that's a good one, right? And then you push it down. And when you push down and you tell the patient, don't allow me to push your left leg down, resist. And when you push down and you keep your right hand below the heel of the right foot, right? When it's functional, you see pressure there. You see like, oh, now it's moving. Okay? That's functional. That's functional. The brain doesn't work like that. Okay? So that's characteristic. Now you have to be careful, right? Because there are some conditions that could be a false positive test, or you are not able to interpret the finding. For example, you have hip pain. Of course, they have a limit effort, so guarding, so you are not going to have a good exam. And when you have cortical issues, right? Like for example, having hemineglect, affecting the same side of the apparent weakness. So that if you have a patient with that, this is not going to help. And the MRI will tell you, right, that you have a lesion on the opposite side, on the on the left parietal lobe, for example. Okay, so you have to know what are you doing. So interpretation with caution. Okay. Now this is another one, very important. Give away weakness. So give away weakness. You tell the patient to put the hands like this, and then you tell the patient close your eyes, and even without closing the eyes, you see that the patient start doing this, going down, like dropping without, like fast like this or like this, but without the pronation. Okay, without the pronation. So you have the drift without the pronation. This is characteristic too. It's a collapsing or give away without the pronation. Be careful, because there are some patients that they can have shoulder pain, and when you have shoulder pain, you do that also. And there's some patients that they have embellishment of the symptoms, but they still have organic diseases. So you have to be careful. But it's just, again, it's not just one test, it's the whole thing. You have to look the whole thing. You have to look the background, everything. Remember what I say about the big cats? It's not just the small head, it's not just the rosette, it's the whole picture, the tail, the background, and that's how you differentiate the cats. Now, this is the most important part of this video. If you are a therapist, or even a primary, because this video is not just for therapists, this video is also for primary care providers and general neurologists, or anyone who deal with functional neurological disorder. How to explain the diagnosis, what to tell the patient, what should you say. So you made the diagnosis, okay? So the patient is having features consistent with functional neurological disorder, with functional movement disorder, then what? So the first step is to tell the patients, but you need to follow these 4 important points, step by step, okay? Step by step. And these are the 4 steps. You need to validate the symptoms. Validate the symptoms, okay? They need to feel like you are paying attention and you care, okay? It's like a trust. And at the same time, you validate the symptoms. This is real stuff. They're not making this up, at least 99% of the time. Obviously, there are some patients that they have fastidious disorder or malingering. That's different. I'm talking about functional neurological disorder, or what we call conversion disorder, which is another name. Conversion disorder. You tell that to the patient, and the patient starts scratching the head. Because what is conversion disorder? It's getting more complex, right? That's why I didn't mention that word. But anyway, you validate the symptoms. You explain the brain network function problem that the patient is having. You tell the patient what they have. Don't start talking. Let me tell you what you don't have. That doesn't work. I used to do that. I used to tell the patients, this is what you don't have. And the outcomes were always bad. So I was doing a very, very, very bad job, I have to say. Very bad job. So, and I accept that. And I start learning and reading how to treat these patients. And words matters. Words matters. And that's why you need to know how to talk to this patient. And patients in general. You need to learn. And you think that you are doing the correct thing, think again. Okay? And if you are not sure, call a colleague and ask the colleague to come with you to watch you how you treat patients, and you will see that many times you think that you are doing a correct job or a good job. You are not. You are not. Going back to the topic. Number 4, give hope. Good news for potential to recovery, which is true. You're not lying. This is true. This is the beauty of this. Because those patients, when you make the diagnosis on time, many of them recover. They have relapse, but they recover. And now you need to learn this speech. Okay, learn this speech. Most important, you know, when you are, I train in critical care as well, right? And you learn, I have many attendings that they were really, really good talking with family and making people comfort care really good. I remember, I'm not going to say the name, but it was really good. That I was like, wow, amazing. But I have a few very bad that I was in my mind say, I don't want to be like that. Okay. So you will see many doctors, and even talking in their first language, they do a bad job dealing with this type of conversation, like goals of care, or telling the patient that they have functional neurological disorder. Important topics. There are good doctors and bad doctors, and the bad doctors, mostly beside personality, is because nobody tell them how bad they are. Okay. So learn the speech, but mostly follow these 4 points. This is my speech. You have my speech there. Okay. And this is what I say. Okay. Always I say the same thing. So learn this. I'm not going to read this. Now, if you ask me, what about if you are wrong? Well, very unlikely. We have data. So when the movement disorder doctor, or actually a neurologist in general, make a diagnosis, they are wrong approximately 4% of the time. So it's pretty good. So it's very, very specific. So it's a very easy diagnosis to make. Very easy diagnosis to make. The problem is the treatment, because many places, like the place where I live, nobody knows about these things. So, and then you are in the air. Years ago, this is what I used to do. I used to send the patient to the psychiatrist. They come back worse. And the psychiatrist don't know what to do with them because they are not depressed. They are not anxious. More than 50% of the time, they don't have any psychological stressors, but you still send them to the psychiatrist. Wrong. No. Number one, they are not ready for that. Number two, many of them, like I say, they don't have any psychological stressors. The best thing to do is send them to physical therapy, but not any physical therapist. Has to be a good physical therapist with experience in patients with functional neurological disorder. Otherwise, will make things worse. Believe me. This is your role. If you are a therapist, PT, OT, this is your slide, okay? The first thing that you have to do is, like I said before, build trust. If the patient doesn't trust you, it's not going to work. You are wasting your time. Okay, discharge the patient because it's not going to work. First step, and the same thing applies when you are in the ICU and you are discussing goals of care with the family. The patient is in the ICU. The patient is in bad condition. And you want to talk about goals of care. Similar approach. You always ask the patient or the family, in this case, the patient, right? The ICU is the family because patient is intubated usually. What do you think you have? You need to know first what the patient think. Ask the patient, what do you think you have? Do you have? Just let the patient talk. Let the patient talk. And if the patient tell you, my doctor, I have a neurologist, the neurologist refer me here because he believes that I have functional neurological disorder. I have functional neurological disorder. And he say that I need to work on training my brain to be functional again. He thinks I can recover. If you hear that, that's a good start. Okay, good to go. If the patient, if you ask and the patient is telling you that, well, my therapist, that my doctor, who I cannot understand what he's saying. He talked like Ricky Ricardo, and I don't understand what he's saying. He says something about functional neurological disorder. I don't understand that. I don't believe that. I think I have MS. That's a problem. I think I have MS. That's a problem, because this is not gonna work. You can do whatever you want. It's not gonna work. He's coming backwards. She is coming backwards. Okay. Now, if the patient is good to go, because the patient know the diagnosis, they know that they can recover, then you always, the therapist, you are the therapist, you say, this is very common. I have many patients with functional neurological disorder, and many of them recover function. And I believe you have potential. Tell them, I believe you have potential. Okay, you need to encourage. You need to be a good coach. This is like having a track and field athlete or a boxer, that you are training a boxer or MMA fighter. So you need to believe on the fighter. You need to believe on the runner, right? Now, if you want to learn more about how to convey, how to tell the patient the diagnosis based on neuroscience, watch this video. Okay, this video from Stanford is really good. This is when I actually, when I saw this video, the outcomes that I have with this patient changed drastically. I cannot say more thanks to the people here at Stanford making this video, because this video, people don't know about this, but when you explain in this way, you see the difference. I was doing the incorrect way. I was very bad, and I improved watching videos like this one. And now I can see the outcomes. I can see the outcomes. Sometimes only with my explanation. If I get the diagnosis on time, for example, the lady with the tremors on the left hand that I show you the videos. So that was an early diagnosis. Early diagnosis. I think a few months, no more than 1 year, for sure. But if the patient jumped from doctors and nobody can tell what the patient has, and you might be a doctor that you suspect, but you don't want to tell, I don't know why, and the patient keep jumping from doctor to doctor, and then 10 years with the same problem, those patients are going to do bad. But if you are able to identify those patients and diagnose those patients, and they believe you, and you tell them the correct thing, those patients do well. Okay. So remember that if you are a therapist, you cannot make the diagnosis of any medical condition, right? Because you are a physical therapist, you are an occupational therapist. You can make the functional diagnosis, but not the medical diagnosis. At least on my time. I don't know if anything changed, but I believe this is correct. So the doctors will make the diagnosis of functional neurological disorder. And this is the best online resource that you see online. You go to this website, okay? This is for UK. Very, very, very good. Very good. Always you need to demonstrate the normal movement. You need to retrain the brain with diverted attention. Videotaping is very helpful, and also mirror feedback, very, very helpful. And explain again how the doctors make the diagnosis. Remember, this is based on positive findings. You don't make the diagnosis of functional neurological disorder ruling out diseases. It's based on positive findings with clear inconsistencies and incongruencies. Okay? That's how you make diagnosis. Now, other recommendation. Remember that these type of patients, they are not used to do exercises. Actually, the majority of the people in the US, more than 80%, they don't do exercises. Maybe 20% of the patients in the US do exercises. So you need to start slow, otherwise they aren't coming back. If you start hard, they will have a lot of pain the next day and the next day and the next day, and they're not coming back. So you have to go slow, and everything has to be functional oriented. Okay? For example, words matter. You have to say the correct thing. You have to learn that you need to emphasize function and not just the bad leg or the bad arm or the tremor on the left hand. Okay? So look ahead, not at the leg. So you have to tell the patient that they need to look ahead, don't pay attention to the bad leg. Just move. Focus on walking, function, instead of left side weakness. So don't think about the impairment. Okay? Walk with rhythm, with music. Use music. Use music. Think about shifting your weight, not moving the weak leg. So remember, stop thinking about the weak leg. Just shift the weight. Okay? Let the leg move forward. Don't say move the leg. Okay? Remember what I say. Words matter. Typically, you see, this is very common, that you see a female. Females is 80% of the patients with functional neurological disorder are females. Okay, 80%, 75%, depends which paper do you read, but definitely the majority are females. But usually there is a husband next to her with a chair, pending, checking that she's not going to fall. You need to tell the husband basically to stay away, because otherwise this is going to be a circle like this. Dependence. This is not going to work. You need to educate the family. You need to involve the family. And it's not just the patient. When you treat the patient, you need to treat the family as well. Okay? Otherwise, this is not going to work. This is the trick here is that is many things at the same time. It's not just the patient, it's clusters of symptoms, but also the family. So it's a package. Okay? But you need to avoid family over helping. What to avoid? Sometimes you need to avoid or try to avoid, sometimes it's needed, like walkers or canes or all these things. During the beginning, sometimes it's necessary because the patient, they're afraid of falling down, and that might help. But you need to tell the patients and the family that little by little we will remove that, okay? Avoid immobilization of the joints. Please don't use that. This is a patient who already was diagnosed with functional weakness. Don't immobilize the leg. If you do that, I saw that. I refer a patient when I came here to Tennessee 4 years ago with functional foot drop. Patient came back 2 months with a brace. And this is when I really start educating physical therapists, because the therapist who saw the patient really mess up. It's just amazing. You're trying to help the patient and the patient come back even worse because you refer the patient to the incorrect therapist. Okay? And this is why I'm doing this lecture. So remember to practice automatic tasks like standing, transfer, stepping, carrying light objects. So it's basically normal daily activity. So, and very important, weight bearing. And important to explain that you have relapse and you will have relapse. This is coming, okay? Now, this is a paper that I want you to read. This is the most important paper if you are a physical therapist, if you are occupational therapist, to read. You will learn a lot. It's very easy to understand. Very easy to understand, and you have all the details, things that you really need. And even though that is 2014, more than 10 years, still is updated. Okay? Now, let me give you an example and we finish. This is the example. Imagine that you have a patient that you suspect, you are a therapist, right? Or you receive the referral, the patient already diagnosed, clinically established, right? Not documented, because documented means that the patient is cured, right? No, clinically established, because there are different type of certainty levels. So functional leg weakness. So the right leg, the patient cannot lift the right leg on commands. Okay, so what to do? Well, let me tell you first what not to do. Avoid paying attention to the right leg. Don't tell the patient, okay, let's lift this leg. Come on. Okay, you are strong. Just try harder. Don't say that. This is not gonna work. Okay, so straight leg raising. Don't do that. Okay, don't do that. And trying to help the leg to, okay, lift. No, that doesn't help. So don't use a wheelchair walking as a main strategy. No, that doesn't work. This is what you have to do. Explain again. You might say, but I told the patient already. Say it again. You need to keep explaining what is the problem, that this is a network problem. It's a communication between neurons, okay? The brain cannot communicate well. So, and use the analogy of the software. So your software, you imagine that you're a computer, you have a computer, your brain is a computer, your software is not working well, but the hardware is working well. Okay? So if we fix the software, you can improve, you can be functional again. And that's the idea. So the movement pathways are damaged, are not working well. So again, it's a communication problem. Start, so the patient cannot move the right leg, tell the patient, stand up. Stand up, okay? Be close to the patient, stand up. And start with weight shifting. Add distraction. Count backward, use music, dual task, you name it. Think about all the things that you can do to distract the patient, okay? Reduce assistance quickly and try to use a treadmill. Treadmill for this patient are really good, and especially you put a mirror in front. Really good. Why? Because you set the pace, and they're not going to fall. Hopefully. So try to go slow with the treadmill, but treadmill, and then when you see that the patient is able to move the right leg with the treadmill, you tell the patient, look at this, look at the mirror, look how you're walking right now, and videotape them, obviously with their consent, right? Because they can see. And also use external cues. Sometimes step on the line, tap the coin, kick the ball. Just play, be functional. Functional activities. That's the main thing. So those patients, you cannot start, okay, let's do leg cord or leg extension. No, that doesn't work. You have to do functional activities. Okay, functional activities. So that's it. That's the only thing I have for you guys. It's a long video. If you like this video, don't forget to subscribe to my channel. See you soon.